I have been working with Hamad Medical Corporation over the past 2 years now, and in that time it's been really great to see the team develop from a beginner level to very much advanced users who are confidently using simulations to manage patient flow in a really complex and rapidly changing healthcare system. So today, Ali Latif and Carolyn Volker will be taking you through some of their experiences in using the software in this complex healthcare system. I should also mention Anthony George, who's been a big part of the simulation team but won't be speaking today. The guys are going to share their experience in some of the simulations that they've used to help make scientific decisions, and they're going to share some simulations with you as well that they use very much for educational purposes. So I would like to hand over now to Carolyn and Ali. Thank you.
Hello everybody, my name's Carolyn. I'm the Assistant Executive Director of Patient Flow at Hamad Medical Corporation in Qatar. Thank you all very much for taking time out this evening or this afternoon to come and listen to some of our talk. My colleague Ali, I don't know if he wants to introduce himself very quickly before I start.
Hi, I'm Dr. Ali Latif and I'm Assistant Executive Director for Strategic Planning.
Thanks, Ali. So first of all, I just wanted to talk about patient flow as a system before we get started. And I think this is really, really important and is really a complex system that we manage in any hospital, any acute hospital or healthcare system in the world. In Hamad, it is particularly complex, as Tom alluded to, and I'll talk about that. But basically, we have to see patient flow as a system. So, and though it sounds very simple, patients come into the ED, they go into different areas there, they go to see and treat and they go home, hopefully. They go in as inpatients, they may go to a short stay, and from there they go to the wards. But we also get onto the wards urgent referrals from outpatients for people who are very ill. We get referrals from different hospitals. And we also have a number of elective patients coming into the system. So quite a lot of demand coming into what is usually a very constrained area, i.e. the ward or beds. And throughout the world, crowding in emergency care is a well-known phenomenon, and I don't think there's anywhere at the moment, whether it's in the US or Australia or the UK or Doha in Qatar, we all seem to be suffering from the same problem, which is trying to maximize the use of our beds so that our patients coming in actually get a better stay. So really within that very complex system or very finite resources, i.e. the beds, there's a lot that we need to take into consideration about where we place patients, the capacity we have, how long they're going to stay, and discharging and when they're going home, because obviously that releases more beds for the next patient. The time of those discharges is very, very important. So coordination between bed and case management systems and structures and staff, usually nursing staff who undertake these functions with the help of clinical doctors and others who design the care pathways, is really, really, really important. So it's all about flow, really is about the patient's journey from their arrival all the way through to their discharge. And it's about clinical services, it's about flow services, but also very much about support services, and key to that all is obviously the capacity. So we're very much involved about getting the patient to the right place, the right time, first time, and we're trying to teach that really as a motto in our Hamad. So to understand that really, it's about understanding the system, so the demand, who needs the service. So what's the numbers, etc., of our emergency admissions, our electives, what kind of specialty they are, because as we all know, a bed is not just a bed. Very often we count up total numbers of beds and we just think, oh well, we've got enough beds in the system, people can come in, but clearly ICU patients, it's about the right place, and it's about getting the patients, the right specialty patients, to the right specialty beds. And that's really important because that affects their length of stay. So cancellations, discharges and timeliness, etc. We need to know all these things, but we also need to know what the space in the ED is, how many ORs we've got, what kind of beds we've got, what the staff is to man those beds, our access to diagnostics, our information systems, and again our escalation and our coordination systems when we just don't seem to manage on a day-to-day basis. So again, I think very important, right patient, right place, right time, first time. So who are we in Hamad, and what does our system look like? So we are Hamad Medical Corporation. We are the national health system in Qatar. We have a great vision for the future. We've got 8 hospitals at the moment, 1 tertiary hospital. We've got about another 5 or 6 hospitals currently being built. We're not in them yet, and so over the next 2 years we're going to have these fantastic new facilities that are going to be built for us. We also have run the the services, the EMS ambulance services. They fall under the national system, and primary care is really very much being developed at the moment. So it's not a primary care system as we would see in other countries that are far more developed than Qatar. The picture I've got here, just in front of you, as you can see on the screen, is the entrance to our ED department, our see and treat area, and I will go into the detail about how many attendances, etc. So Qatar is a country that has expanded over the last 10 years. The population has grown phenomenally. We are actually building a city. Everything is being built around us. The buildings are absolutely incredible. It's a fantastic vision for the future, but we're not quite there yet. And within that, we have a healthcare system with our tertiary hospital, which is about 30 years old, and we're waiting to move into new facilities. But we are experiencing an undercapacity, and so making sure we make the most of our capacity is really, really important. So I'll talk about our major Hamad General Hospital, which is our main hospital. It's a really, really busy hospital. It's obviously got a trauma center. It's the tertiary hospital, so it does all the tertiary, it's academic teaching hospital and does all the tertiary things you would see. At the moment, we only have within that hospital about 556 beds. We do have other district general hospitals or more local hospitals, and we have specialist hospitals like the heart hospital or the cancer hospital, but basically the bed base of them is about 170, and they're very, very specialist. Our emergency department at Hamad General Hospital is not the only one we have. We do have in our Al-Wakra hospital, we have an emergency department, but Hamad General Hospital is the main tertiary hospital in Doha, which was the first hospital that was built. And because we don't have a well-developed primary care system at this moment, I think many people come to hospital because that's what they've known in the past, so they come to the ED. We see 1,500 attendances per day. Now that is a phenomenal amount of attendances and is probably one of the largest healthcare systems coming into ED in the world. About 800 of them usually go home and come through our see and treat department, but it's all, if we work it out, it's about 1 a minute. We do have about 80 admissions per day. We obviously do the whole range of elective procedures and some very complex procedures, and we have visiting surgeons coming from all over the world to complete those, and we do have a full range of outpatient services. So our next slide. So just to talk about that, so we have about 45 to 50 what we call pending admissions today, usually in the morning. So in the morning we can have about 40 to 50 patients waiting in the emergency department for a bed, because as many as you will know there or get a feel, 500 etc. is not an awful lot of beds for the throughput that we have. We usually have that broken down into about 6 critical care, about 10 cardiology, surgical, medical, psychiatry, and sometimes we have a crisis that escalates into the PACU, which is a recovery room, and therefore patients who've had their surgery, emergency surgery, end up waiting for a bed in the recovery room. A lot of electives do get cancelled, and we have some very long waits for beds. So for us, getting to grips with this kind of situation is really, really important, and maximising our capacity is obviously really, really important too. Next slide. So what did we have when we started? I mean, we've moved forward quite a bit, and we have got a great plan to move forward even more for the future. But I think we have a PAS Medicom system. It wasn't fully utilised. We've just moved on to Cerna Millennium, which is their final launch in our main hospital just a few weeks ago. We had no electronic booking systems for inpatients, so basically elective scheduled inpatients were done by the doctors in their diaries or on Excel spreadsheets, but we are now tackling some of that. ED information systems we didn't have. We didn't have bed management or coordination structures or staff. I think the system had grown so much that system awareness, etc., was quite difficult, and people have kind of normalized some of the things they see. The information that was collected and reported to our Supreme Council or our national bodies was very high level data, as is per normal across the world. Things that would have been reported to, for instance, the Department of Health or the board in the US, etc. Very non-specialty specific, but not really operational data. We did have a lot of data, I mean, because the staff are actually really good, and they kept quite good manual records of all of this, except it wasn't on the computer. One of the things we do have here is fantastic staff. We have great nurses, great doctors, and very, very willing staff to make changes and to move forward. And it is actually quite humbling at times to work with them and to see how much they take things forward and what they can do for patients. So next slide. So what have we done so far? So we have spent a few years just really looking at clinical flow management and coordination. We've put in bed management staff, and we've trained and taught them, and we've got 24/7 bed management and coordination in our main tertiary hospital. We've got really good bed managers in some of our other hospitals, and case managers who help take things forward, and we keep on with that, and we're recruiting daily, and we'll get more staff and more training. We've opened up an acute medical assessment unit this year, which has helped us phenomenally with our medical borders in the ED. We've had a lot of relocation for long-term patients. We have a lot of long-term patients here, as I mentioned previously. The tertiary care here, as in long-term nursing homes, etc., for long-term care patients, is in the very initial stages of development here. And having most patients used to be in a very family cohesive culture, I think it's not common culture or practice to put older or most vulnerable patients in nursing homes. And so these patients have tended in the past to be in the main hospital. So we've had a lot of beds utilised by these patients, and of course the throughput there does affect our capacity as well. So we have created new facilities in the last year for relocating these long-term patients to, so that they get what they need. We've created quite a lot of corporate awareness around flow. As I've mentioned, we've got a number of new facilities opening. I think we've got 3 hospitals opening next year, and they do look fantastic. We've got another one opening up later on in the year, and we've got, I think, quite a lot of plans for MICU, SICU, and TICU. We're getting new buildings built for them. We're getting a new ED built right as we speak. The builders are on site, and the building is going up every day. And we are opening up about 20 new ORs in the next month. So there's lots and lots of things happening. And being part of one system, we're fairly unique in that we want to put in place, starting in December this year, a system-wide bed capacity management system so that we can all see each other's capacity across the system so that we can start to use everything in a much more coordinated fashion. I think what we're also looking at is we're looking at putting in, we've just got the Sana Millennium, as I mentioned. We've got a surgical booking system on there, and we're just rolling out now. We have done pilots for surgical booking in urology and bariatrics, which have been very successful and reduced our cancellations, and we're now looking to roll that out across all of the specialty as we speak. So huge amounts of work going on at the moment within our system. And this is just, as I said, I just wanted to show you the kind of things we've done. So we've actually, this is our medium time in the ED, and so we've managed to reduce that quite significantly over the latter half of 2015. Part of that has been looking at all of our information and doing some of the things we've talked about, but it's also been about modeling some of our capacity on Simulate and using our tools to do that. And we had a very, very insightful colleague, John Bolton, who worked with us. He was a great fan of using simulation tools, and he's the one really to take a lot of credit to getting us started on this. He's gone back to the UK. And we miss him very much, but I'm sure he's doing great things over there too. But he really got us started, and we did a lot of work on getting this graph, and that was really just to show you things, even though the system is very busy, there might not be enough capacity, there are still things we can do to make significant changes for patients, and that's really important. Next slide. So I think we started with a vision by, as I mentioned, very insightful colleagues. We purchased the software. We set up a very small team. I think we only had about 5 licenses in the beginning because nobody was very sure about what this was going to do. I mean, why weren't we concentrating on the day-to-day running rather than trying to model things? But I think it's really important to get ahead of the game. I think I have to mention this. I'm a nurse by background, but also done a lot of management and operations, clinical operations and operations. And I think very clearly for us, success factors are how you put the team together. So we had analytical, we had our flow champions, as in John and myself, obviously. And obviously we have a very great lead in Ali, who is our clinical lead, but also works in strategy and planning. And we've had all of our training sessions in Doha. Being so far away, Tom has been over a couple of times, and he's taught us in the training that we needed to do. We've completed a few models, and we also did a big presentation this year at the Middle East Forum, which gets a lot of people from, we got a lot of people from IHI in the States, etc. over as well. And so we played a few games, etc. there in the forum, which was very helpful and useful. So I think, just to reiterate, this is our ED department, just a few, this is our old ED, our new one will look much more snazzy and whizzy than this one. I think we have to recognize it is a system issue. Information is really, really important. We do have to win the hearts and minds of our chiefs and chairs. We have to keep, our chiefs and chairs will be the people who head our service. Our chairs are our clinical leads. Might be called clinical directors, etc. in other countries. Patient focus is absolutely critical. Perseverance, it has not been easy, as I'm sure we can talk about when we answer some questions. We have to take time to celebrate success, although we may not have done a lot of things, and many of you will have done some of this and more. We've done quite a lot for where we used to be. And I think we do have to take time to celebrate that and to rejuvenate ourselves and move on to the next. And of course, quite clearly, we need to have will from everybody to want to change. And I think those are, for us, the key elements. So I think I'm going to hand over to Dr. Ali now, who will talk through some of the models we've done, some of the success stories and how we've taken that forward. Ali, over to you.
Thank you very much, Carolyn. Yes, so in this part of the presentation, we're just going to take you through a few of the models and give you an understanding of how we developed them and what impact they had on the running of HMC. So the first one we really got to grips with was the National Blood Donation Centre. As the name suggests, it's the national centre and receives 50% of all the donations, blood donations in Qatar. The other 50% come from mobile vehicles. And the problem with the current unit was it was really under capacity, it was a dated design, and there were lots of issues with even the internal flow within the department. On top of that, there were a series of major incidents across the country, and whenever any major incident occurred, the unit itself was just overwhelmed. Lots of volunteer blood donors unable to donate, people waiting for very long periods of time, and lots of frustration and stress on the staff. So we were brought in and asked really a simple set of questions and around estimating the capacity of the blood donor unit. So the main questions we were going to answer through a simulation was, what's the optimal configuration of the blood donor unit on a sort of normal day? What's the optimal configuration of the blood donor unit in the future with the estimated average annual blood donation of about 30,000? And then what would be required in a major disaster? What sort of unit setup would they require in a major disaster? So we have three main questions, and I'll just take you through how we did that and how we set up the simulation to answer those questions. So here we have the blood donor unit. I'm not going to go into very much detail as to how the detail of the model itself, but as you can see, it's quite a complicated model where the donors would go through multiple stages of registration, screening, examination, and then on to actual blood donation, and then observation, and then going back and exiting the unit. So the good news was that the unit itself had collected lots of information previously, and so we had a whole host of really rich information and timing information that we could use and simulate. And I think that's an important point to make, is actually the Simulate, which is a discrete event simulation modeling software, does require quite a lot of detailed information, and the more information you actually feed in, the more realistic and valuable the model will become. And so we had that information. We had the team that was the donation team that was really quite excited to be part of this project, and obviously we had people like Dr. John Bolton, as Carolyn has already mentioned, and Carolyn, myself, and the rest of the team supporting the development of the model. And it was very much a first simulation, so we were also learning as well as applying, so it was, as I said, quite a good learning experience for all of us. So what we found was the current setup of 4 reception rooms, 1 screen, 1 exam room, 6 donor chairs, and 10 parking spaces was not quite the right configuration when we ran the simulation model. What we found was the major as I said, bottleneck in the system was actually around registration. It was also around screening and examination, and what we found was actually, well, whereas before it was a separate screening and examination station, we could actually combine it and make it much more efficient, and we again tested that using simulation. So what we found was actually the configuration, as you can see in the table, is actually quite different from the current to the recommended. And then when we move on to the future, the only real change we actually see is the number of parking spaces required. That all was fine, but actually in a disaster scenario, that whole configuration goes out the window. What you actually see again is that the rate limiting sort of node in the donor pathway is actually the screen and examination station, and you need actually 9 versus the 3 that would normally be in place in the recommended scenario. And if you look at the graphs below, you can almost see how the magic number 9 changed the dramatically reduced the time in department in a disaster scenario, and also reduced the number of car parking spaces you would require in a disaster scenario. And again, that was not intuitive. We weren't sure exactly what the optimal configuration was, and simulation really brought that out to us. And again, it was a very much a surprise to the staff themselves. They had originally wanted to actually set up 12 donor chairs in a normal setting, and we actually proved that actually you don't need any more chairs. You actually need more registration booths, and you need more screen examination rooms, and actually you would cope with the sort of high volumes you would be expecting in the future. What it also showed was the fact that a disaster scenario would not fit in that unit as currently designed, and we would probably need a surge capacity elsewhere to deal with a disaster rather than actually dealing with it in the unit itself. What's also very important to note is that actually the simulation model itself identified quite a lot of savings from the original design that was done before we actually simulated the optimal configuration. So I would say this is the first time the organization woke up to the fact that actually simulation can be very useful, and actually it can actually save money rather than just being a bit of software that some members of the organization are literally playing with, and actually would make a very big difference to the costs of capital, costs of operating costs, workforce costs are all tied into how optimally to configure your service. So that was the blood donor unit, and I'm happy to answer questions about that if required. We'll move on to another unit, which is again probably, I guess, more central to the acute running, or the running of the acute hospital, which is the critical care unit. Now, just as a bit of a background, it's currently at 23 beds. Again, inadequate capacity, and again, Carolyn alluded to the fact that we're really under pressure, the population boomed, and a lot of the bed capacity in our system was just not enough. So a lot of patients that were supposed to, or identified as needing to be admitted to the critical care unit, actually ended up being seen in the emergency department and then being treated in the ward, purely for the fact that we just did not have the space to accommodate them. So the original plan was to actually expand to a new 44-bed facility, but the problem with that was the oil price crashed, and then a lot of the capital programs were cancelled or postponed. Now, that was quite a setback, but it allowed the critical care team to actually take a step back and ask themselves, actually, what is the ideal capacity of a critical care unit? And what they also had was some really important KPIs about wanting more than 99% of patients being identified as critical care actually ending up in the unit, and also patients actually from being identified actually quickly entering the unit itself. So we had some KPIs to work with and set up our simulation model. What we also did was, while we had the time, actually started engaging with the clinical team and actually asked them, well, what you've got a setup, as you can see at the top left-hand corner of the slide, a setup, a pathway that's quite simple. People come from the ED to the MICU to the ward and either go home or require long-term care, ventilation, or home care, or nursing home care, essentially. And what we did was work with them to develop a ideal pathway that they were looking at. And what they did was look at a new MICU, but a new unit that looked after the ventilate patients who had difficulty weaning. And then furthermore to a transition unit that also again helped within the weaning process, that for those that are really quite difficult to wean off the ventilator, and finally off to long-term care or home care. And it was through this pathway that we recognized that a lot of patients actually would benefit from more intensive weaning and actually hopefully be weaned off the ventilator in the longer term and help the system and patients as a whole. So that was the plan. So we decided to again develop a model. Again, this is actually quite more complicated, more complex than the blood donor model. We had patients, as you can see from the left, and again I won't go into too much detail, but essentially we set up a pathway of patients going through from ED to the MICU, as you saw on the pathway, to the ward and then being discharged. And then we had a separate arm of the model looking at the weaning unit and the transition unit. One of the most important steps in developing a model and again engaging with the clinical team was validating it. So we constructed the model using part of the data and then ran it and then validated the results with the data, with looking at the data and working with the clinical team. And the reason why that's important is it gives the clinicians and team members the confidence that the model is replicating the reality. And then once they're engaged, they actually own the model itself, and they can then actually experiment and know that the outputs of the model and the way they're experimenting, the outputs would be actually a reflection of the reality if they actually configured the pathway in that way. So it's really important. One of the most important steps in building a model, as people probably well know here, is the validation phase. And so we built the model and we outputted some interesting results. So what we found eventually was, once we'd run lots of different scenarios and played around with the pathway, was actually that they didn't actually need 44 critical care beds. What they needed was about 39 critical care beds. They needed about 20 weaning beds, and they needed a further 15 transition beds. And that configuration allowed the critical care unit to drop its occupancy to 70% again, which was really important because once the occupancy rose higher than 70%, you started seeing patients waiting in the ED, delays, patients being diverted away from ED to the ward, etc. So the way we set up the model was immediately the KPIs were right there in front of the team, and they could actually monitor the impact on the KPIs based on the way they configured the unit in terms of capacity. So what it did was highlight the optimal configuration again, just as we had witnessed in the blood donor unit, but also really enabled the clinical team to reconfigure their pathway in what they thought was the ideal way. What was really important in this model, and on top of that, was the fact that it was recognized as the best business case, business plan across the corporation because it had such a high level of evidence behind it. And again, the corporation took notice, and what they said was actually from now on we are expecting any major capital program or any major clinical pathway reconfiguration, if it's in the business planning process, must be driven by a simulation model similar to this. So we had in fact not just built the simulation model, we had in fact modified the business planning process for the whole corporation, because the corporation recognized the fact that this simulation model is set to actually optimally configure the hospital, as well as optimally optimally configure the, or I'd say is probably optimally to produce an optimally cost-effective hospital services through simulation. Now, I'm not saying it's perfect, but it's a brilliant way of bringing clinicians, modelers, analysts together, and business planners together, and look to see, understand the context, and then produce models that actually have an impact on patient care, save money in lots of instances, and actually enable and enhance quality of care and better care for our patients. So I'm going to stop there and hand back to Karen. Again, I'm happy to answer questions about the models at the end of the presentation.
Thank you, Ali. I think, as Ali's alluded to, it is an excellent way to engage staff. I mean, clearly a model remains a model, but it's the start of looking or engaging staff so that they know that actually what they might have been their perceptions as may or may not be correct. And it validates them and gives them a real chance and opportunity to actually shape what it might look like in a virtual reality almost, without actually affecting some of the patient care. They can then go and try some of the concepts out afterwards, but they can actually put together things on a computer screen and then work with it to see how they can take that forward virtually, and then go and practice some of those that look right. We did a flow game that Simulate have developed on our Middle East forum. We had about 200 participants from all different backgrounds, and whilst it was just a game, it was really, really useful for the staff to see simple flow concepts, and also to see how, as a team, because we do in healthcare tend to work in silos, and as a team it was really useful for them to visually, we had a huge screen, and so things were changing on the screen as they were making decisions, for them to see that as a team they had to function to make it work. And I think the value of some of that is really, really important. I think we've also used it to explain very simple flow concepts, simple flow models. We've done a few that we use for teaching, such as variation, which I'm sure many of you have spoken about. Occupancy, which as Ali alluded to in the critical care model, and bed capacity. So occupancy is an interesting one, and we're going to go through a couple of bits about occupancy in a minute, and then I'll talk through occupancy. So I think we're going to look at a model, the model we did for occupancy, and the question would be, what is the ideal bed occupancy, and why is it important? Why does it matter? Well, I think is the proportion of utilized beds in a ward, and it's normally quoted in many information or many business cases, etc., as an average. So 2,000 admissions at 5 days each, 10,000 bed days is 27.3 beds, divided by 30 is 91% occupancy. And a commonly quoted target on acute ward occupancy is 85%, and that comes from Erlang's queuing theory, but he didn't quite say an occupancy should be 85%. But it's kind of been adopted as the occupancy level we should all aspire to if we want to get patients through the system. However, that is not always the case, because occupancy is very much related to the wait time that you would have. So for instance, in the critical care model, if you wanted a wait time of 1 hour in the ED for somebody to get to the actual specialist unit for their care, then your occupancy probably needs to be slightly different to the 85%, and as Ali showed, in a particular instance, it was around 70. Now this is always really hard for people to understand, because let's relate occupancy to beds. For example, if you have an occupancy of 70%, it means that at all times you should have some vacant beds, and you shouldn't be filling those beds with new patients. You should always be keeping them beds for the next patient to get into in 1 hour. That means your escalation processes need to be escalating far sooner at 70% rather than when we normally in hospitals get to the point when we escalate when we're at 110%. And that's the whole thing about occupancy. And of course it has been linked to high risk, because staff get stressed, we have no space, physical capacity is reduced, people get moved to the wrong places, etc. And people start doing things, the adverse events and incidences increase, and also increased occupancy and crowding, particularly in EDs, has been linked to increased mortality and a huge number of other events as Singer, etc., as research has shown. Okay, so low occupancy means, less cost-effective services is somewhat not always the case. So let's move on to the model and play our little game. So we're going to look at the simulation now. Take a moment just to put it up. So this is a picture of a lovely hospital, Al Wakra, and we're going to look at the bed capacity versus bed occupancy. We're going to run the simulation, and then we're going to ask you some questions. Okay, so here we go. The simulation is going. We've got 84 beds there. We've got 8 hours. Our average length of stay is 4. And the patient's waiting within target 95 and our bed occupancy is 90. So the next part is a couple of questions we're going to ask you. So we're just going to the questions. So the questions which you'll do now is in the voting poll is how many beds do we think we need to ensure that 100% of our patients wait less than the target? So we're going to ask you just to choose one. So you can vote now, I think. It's a quick poll. Okay. So, right. So the answers here, right, so I think we had quite a lot of 67% of you saying 90, but the right answer there is about 95. But let's have a look at the simulation again just to see what our correct answer was. So we're going to run that again just to get the right answer for the question. Yeah, so we needed about 96 beds. So you weren't too far out, so congratulate yourselves, everybody. There we go. Okay, so that would give us an occupancy of about 79%. So I think that, yeah, that was to answer the question. Yes, thank you. Right, so again, just to reiterate, I think, so what determines the ideal bed occupancy? Well, I think it is your demand pattern, i.e. scheduled versus unscheduled, emergency versus elective, etc. Any variation you have in your admission rate. Acuity, how long can patients, or your wait times, how long can patients afford to wait in the emergency department? And it's very true as well, it's not just about the emergency department, it's a bit like for those guys from the UK, if you're doing 18 weeks, you know, how many queues do you need to, you always talk about the wait list, backlog, etc. Now, I've done quite a bit on 18 weeks as well, and it's about the target time, so you may need more resources to get down to the target times, and you'll need less to maintain it once you're there, but it's very important that those wait times for each of the different areas are modeled or simulated to see exactly what it is you need, because these are extremely expensive resources that you have to put together. And of course it is also very much about the discharge pattern and the variation in the length of stay and discharge, and also the variation in the timeliness of that discharge, because it may be that much of the discharges are happening fairly later on in the day, but actually your real demand means that you need the beds very early in the morning, and perhaps by spreading it out during the day that you've got a really good, you reduce that variation throughout the day, you might actually reduce some of that and the need for some of the additional resources. We find that often, I think, where we have peaks of discharges on a Friday and very little over the weekend. I mean, we have it here on our Thursday, because our Thursday is everybody else's Friday. Friday for us is a day off. And I think that very often we have huge peaks of discharges on a Thursday And we have less over a weekend, and a lot of doctors, clinical staff, obviously in anticipation of the weekend, so they're not going to get called for discharges. Think they're doing us a great favour by discharging everybody before the weekend, but actually all it does is give us huge points where we admit lots of patients on the Thursday afternoon and the Friday, and they all go home at the same time, and we don't have a great flow pattern. So it's better to be consistent across the week with numbers than not, to reduce that variation. So I'm going to move on at the moment to the next slide. So the lessons we have learned, I think, really important. Visual impact is really important. I think our staff love the fact that they can see things, and of course with Simulate you can build fantastic models. We've just shown you some very simple models, but I have seen some really great models where you have little men going around the screen, you have little ambulances pulling up, and it really makes a difference to if you're engaging a big group of staff together. It's really great to play games and to teach concepts and to allow the staff to use it as you're going through it, I think is really important. I think the makeup of the modelling team is critical, because I have looked here, we had a couple of people building models. So for instance, we had a model, a fantastically aesthetically pleasing model built for our ED department, and it showed, for example, the weights and everything going through, but we had a huge problem with 80 people kind of not getting through the registration at the beginning, and everybody was really happy, and the recommendations that were put forward weren't quite what the model was. So it's really, really important, I think, that on the modelling team we test, there is some clinical knowledge, and we've been very fortunate to have that. You certainly need some analytical knowledge too. I think the Simulate team have been absolutely excellent in helping us. Tom has been over, as I said, a number of times and is always very helpful on the phone or by email. And I think really, really important that once you've collected all that information and that information is real, that is tested with the clinical team, and then allowing them to play with it and build it and change their care pathways once they see what it shows them. I think it's really valuable. It's also very, very important that it takes time to learn and build models, and I think I'm not a technical person. As I said, I'm a nurse by background. I've done flow and operations for a long time, so I know what we want to do. Putting it onto the computer, I do require support from an analyst and from other teams, and I think that is really, really important. And I think it does, as Ali said, it does require executive support and buy-in, because very often I think modelers or analysts get stuck in a little room and they build models and nobody uses them or makes them happen. So having attached it to the flow team makes it really important, because it's a big agenda for us. I think models should align with corporate objectives, because they do take time and it does take effort, and I think people need to be making it happen. And as we've agreed as a corporation now that any of our big major things will go into it needs to meet with our corporate objectives, and of course for me it's a great tool for teaching principles of flow. So just moving on, I don't know if I've got any more slides. So summary: to truly perform well we have to understand the whole system. It is very important to analyze our system scientifically. We haven't got room for errors. We have to maximize the little capacity we have. And it's really good to be able to test solutions to problems without increasing patient risk. And I think that's probably about all we've got. Now just open for questions and hand over to Tom.
Thank you very much, Caroline, and thank you, Ali. It's great to hear about the success stories of people using the software, and it sounds like you've had quite a lot. So we've got lots of great questions here that have come in. We're going to get through as many as we can in the time that we have left, and then of course we'll be able to put the rest up on our LinkedIn, and you'll be able to download this video. So to start off with, how did you win over staff that may have been skeptical about the approach?
Do you want?
Happy to answer that, Carolyn, if you want.
Yeah, yeah, absolutely, Ali.
Yeah, so I think a lot of staff initially had preconceptions about what their ideal, for example, in blood donor unit especially, what their ideal unit should be configured. And all we did was take their information, run it through a structured model like through Simulate, and fed it back to them. So they recognize the information, they recognize their own data, they recognize the pathway that we had to use. So all throughout the process we actually had engaged them. So once they saw the outputs that were actually sometimes very different from their earlier perceptions, they could see how we had got to that stage. So I think a lot of the cynicism or a lot of the skepticism went, and I think it just underlies the importance of engaging the clinical team throughout the process, so they understand it's not a black box. We've taken their information, we've transparently put it into a pathway that they recognize, and the outputs are just the outputs from a simulation model and nothing more than that. And I think that really is the power of something like simulation, but it needs that sort of engagement to work properly.
I think just to add to that, I think that putting the model on a very big screen and being able to change things with the group of staff in the room, so they may say, oh, okay, if you just change those admissions to this is our demand, can you do that? And being able to do that quite quickly in an interactive type of way actually really helps to engage them, because they feel very much part of the model building process. So I think that's useful too.
Brilliant. So kind of in a similar area there to do with validation, how did you carry out the data collection, and how did you validate the basic model before optimization?
I mean, I can answer some of that, I think, and then Ali can come into that. I mean, we have collected manually lots of information. As part of the flow team, we have set up systems for bed management, etc., and we captured all of this and had been doing that for a couple of years. So we had quite a lot of good information from our ED department, and then Ali will talk to you about how he took some of that and they've developed that and worked with the doctors to put that into the system to make it as real as possible. Ali, do you want to say anything on that?
Yeah, so I mean, we were lucky in both instances in those models that they had actually a registry of information that had been running for a number of years. So we had a wealth of information that we actually didn't need to collect much. We did need to, so there's two aspects of validation. So we did need to actually see and actually directly observe some of the timings just to make sure what they were recording was accurate. So there was initial validation to make sure the actual registry was accurate. In terms of validation in general, what you'd normally do is if you've got that wealth of information, if you don't, you have to collect it yourself, and then when you get to a stage where you've got enough information, ideally you'd split it up. You'd use part of the data to run the model, and then use the other part of the data to validate that model. So essentially you're using the same, you're separating out the data and then comparing one part of the data with another, and it should, in theory, the model should reflect the data that you've separated out. Obviously that's important, and you can actually statistically then compare the various measures and make sure they are valid. And also obviously the clinical teams themselves will also give you that face validity as well, so they will recognize the information and say, yes, that's exactly the number of patients we see per day, for example. You need that sort of also face validity from the clinical teams themselves.
That's great, thank you. Okay, one more. How long did the critical care model take to build, validate and deploy?
So I think from initial meetings to the end point, I think it took around 4 months, 4 to 5 months really. And yeah, so it does take time, and that's why it's really important that it's an important, it's important that it's a project, as Carolyn has already said, that aligns with the corporate objectives and that will have an impact on patient care. And it took 4 months, and it took about 3 or 4 of us from the team constantly engaging, building the model, modifying the model, presenting, validating. It does take time.
And I'd also add to that, though, we do have a very small team who also do other things. So, I mean, although it took 4 months, that is also engaging all the staff and a lot of change management. And so if you build up a team that's doing that full time, I think it goes quicker. It will be quicker than 4 months.
Great. Okay. How easy is this tool to use and understand? That's both from a decision maker point of view and an analyst's point of view.
I'll talk about the decision maker part. So I'm the less technical member of the team, as I call myself. Basically, the program is fairly easy to use, but my role doesn't allow me the time I would get to be using it as much as I would like, put it that way. But from a decision-making point of view, I think it is really, really useful to see, to build the model and to make decisions on what we think is happening based on accurate data, and work with the teams to take that forward. That is really, really easy to use in that sense. For me, I think you do need to spend some time with it, and you just have to learn the system. It's not a difficult system to use. You just have to, it's like any new program, you just have to spend some time with it and learn it and learn the fundamental concepts. And I think that's the bit that we do need to acknowledge. And it depends what your role is. But decision making, I think, is, once the model's built, is fairly easy to see. It's pretty self-evident. You can look at it and you can see, oops, yeah, okay, that looks pretty good, and it enables those decisions quite well. I'll let Ali talk about the more detailed part of building some of it. He's really good at that, so I'm sure he's not finding it challenging at all. But Ali, do you want to say a few words?
Yes, so it's actually surprisingly quite easy, as Carolyn said, to understand at a basic level, and but moving beyond that, it uses a Visual Basic programming language, but it's actually really quite easy to pick up. But as Carolyn said, it requires the time and effort to be invested in that. Yeah. And to be honest, as I said, I was surprised how actually it didn't take that long to really start getting to grips with the more complex modeling, the more complex programming that underlines the model, and actually really brings out the value and power in models. You can build a simple model and that's fine, but it's really to get to grips with some of the programming behind it. I think it does need time. It needs the right sort of analytical mind, but I think most people, if they put the right sort of time and effort in, I think they'll find that actually it's not as hard as they think.
Yeah, I'd agree with that.
Great. We're going to call time on the questions there. Of course, as I say, we're going to put them online for everyone to see and get all the rest of the answers. But it's been a pleasure having you both today. So thank you very much.
Well, thank you. Thank you for inviting us, and thank you for listening to us.